endovascular aortic treatment, and he's from United States, Baltimore, Maryland. Dr. Criado will be talking on gaining a better understanding of IMH of the thoracic aorta and when to treat.
Thanks very much, and good morning. As we discussed yesterday during the panel session at the opening, this is part of the so-called acute aortic syndrome. This denomination is being increasingly used all around the world. And it was a term coined on a paper published in 1998 where these authors thought appropriate to group three aortic conditions or pathologies together, dissection, PAU, and IMH, because they share a very similar clinical presentation and the need for urgent and occasionally emergent treatment. The most salient common denominator is the so-called aortic pain that in its typical form is of course acute. It tends to be located interscapularly. And interestingly, and most significantly, it tends to be maximum right from the onset, from the beginning, unlike a typical coronary insufficiency pain that gradually builds over time. Patients tend to describe this pain not only as severe, but ripping is a common recurrent term that Anglo patients use to describe it, perhaps pulsating and the like. Of all three conditions, intramural hematoma remains somewhat surrounded in mystery and poor understanding, as we discussed briefly yesterday morning. It is thought to be caused by hemorrhage into the outer layers of the aortic median from rupture of the intrinsic vasa vasorum that provide blood supply to the aortic wall, but without an intimal tear, which is thought to be the defining characteristic separating it from dissection. To add confusion to an already confusing picture, in the recent past, there have been a number of anecdotal reports and discussions describing cases both at open surgery and autopsy of IMH cases with an intimal tear. Unclear whether it was a primary phenomenon or a secondary phenomenon of IMH cases evolving into an aortic dissection. Is said to account for 10 to 15% of acute aortic syndrome cases. It can be a type B or a type A, light dissection, and more about that in just a moment. Evolution to full-blown classic aortic dissection has been described to occur in 16% of IMH patients. So not a huge number, but a relatively significant number to keep in mind. When you compare broadly IMH versus aortic dissection, IMH patients tend to be older. And interestingly, IMH emerges like sort of like the flip side of aortic dissection, where 60% are type B and 35% are type A, the exact opposite of what we see, at least in North America and in Western Europe, for aortic dissection. Interesting. Not sure why. The natural history of IMH is, of course, extremely variable, and there are a number of possibilities, some better than others, as you can see there. It does show a remarkable propensity, perhaps in the majority of cases, if not interrupted by our intervention, to regress and spontaneously resolve. It goes totally away within a few weeks, perhaps in the majority of instances. The problem is to identify those that are likely to follow that course as opposed to those that are going to become complicated and occasionally end up in a serious complication or even death, which does happen on occasion. So it can progress, as we said, into a classic case of aortic dissection, whether type A or type B, aortic expansion, rupture. There is a wide variability in published reports, and remarkably, there is